Hello and welcome to Healthcare Voices, where we bring you authentic voices behind healthcare innovation and impact. I'm your host, Katherine Cummings, former clinician turned healthcare technology advocate, and today I have the privilege of speaking with physician's assistant and neurohospitalist Tori Sutton. Tori and I worked together in the intensive care unit many years ago, and she is a shining example of what compassionate and comprehensive care looks like for patients and their family members. Tori is a very passionate person about end of life care and about dissolving health literacy barriers between providers and patients. I am thrilled to have her on the podcast today. Thank you so much for joining us, Tori, and welcome.
Hello. Good to see you.
So my first question is, I'd like to actually hear a little bit about, your journey about becoming a physician's assistant and really what drew you to specializing as a neurohospitalist.
So, what drew me to being a PA is a little nondescript, but I grew up around a PA program. My mom was one of their financial coordinators, so she helped the students figure out how to pay for things as well as budget for the program itself. And so they were kind of all my big brothers and sisters. After school, I went to the PA program and I hung out with my mom until she was done working, which equated to hanging out with the students. And so as the years progressed, they would take me to the baseball games with them or take me on their class float trips or, whatever. And so I don't really ever remember thinking, oh, I want to be a ballerina or, anything else. But I don't also remember like, woohoo, I'm going to be a PA. It was more of they seemed very happy in their career. They seemed to have a very good life balance between career and home. And they went on a lot of fun float trips. So it just sort of seemed like the natural progression. I applied actually in high school and I was accepted into the pre-PA program. So from freshman year until I graduated, I was always kind of a PA student. They guided me through the undergraduate portion and then directly into the programs.
It's nice to know what you want to do early in life. I had no idea. So it's
25
nice to
years
have
is a
kind of
great.
a set career path already kind of in order for you.
I don't know, 25 years later, I'm still amazed I'm still doing this and sort of looking for a second career as retirement nears.
I know before the podcast, I asked you if there were any pressing topics in healthcare that you feel really passionate about. And you said end of life care. And you mentioned the importance of families having those end of life conversations, maybe even before a loved one even becomes ill. How do you shape your approach on that topic with your patients and their family members, especially when it's kind of an emotionally charged conversation to have and I think really fraught with misconception?
I think, end of life care and patient or colleague education kind of go hand in hand. The first thing with end of life care and end of life conversations is patients and families want to have these with their primary care doctor, the person they know the best, they're the most comfortable with. Unfortunately, they typically end up being done here in the hospital during an acute event with a bunch of strangers who are us as healthcare providers. I did it definitely a lot more in the ICU. As a neurohospitalist, I definitely still have to have those conversations more regularly with stroke patients or dementia patients, but also, like, I have a patient right now who's only 49, way too young to have these conversations with her kids, even though they're 20s, but who at 49 has this conversation if you're not me or another healthcare provider. But she was a cardiac arrest at home and now she's almost brain dead. And so we're left having this conversation of what would she want to do? Because in the end, it's not what we want for our parents or our siblings or our child or anybody. It's what would they want? And so I've had, these end of life anoxic brain injury after a cardiac arrest with the parents of a 28-year-old or the kids of a 49-year-old or the kids of a 90-year-old. It's the same conversation despite the age. And even the 90-year-old doesn't have, their kids still don't have that information of what would mom want. So, and then they're fraught with the guilt of, am I killing mom? When that's not the case. So
I think it's really hard to have those conversations, though, with our loved ones. I mean, no one ever really wants to talk about death, right? But, it's an important part of life, and it's important that we know what people in our life that we care about want for their end of life care.
it very much is, and it's not a pleasant conversation. Unfortunately, the reality that healthcare has always brought out more so in my life is you never know when it's the last day, the last hour, the last conversation. And so you should seize the day, but also be prepared for what inevitably is coming. Yes, we all want to die in the middle of the night of the heart attack, but that just because of medicine and because of medical technology, we can keep people alive on machines for what seems like an inevitable endless amount of time. And so really those conversations are essential even at a young age because we can do so much to prolong life.
I know those were part of the conversations that we often have in the ICU with family members too, is, we have all of the means to keep people alive, but quality of life is part of that conversation too. What is the quality of life going to be long term for this person on a ventilator, on ECMO, on really anything extra, right? What is it going to look like if they are able to get out of the ICU?
Yeah, I think it really needs to be normalized in our society to have those conversations. There are a lot of intricacies to that conversation, but even just the basic of, you know, Mom, if your heart stops, would you want to live on a ventilator? And I think as medical professionals, our role in saying 6 months from now, this is what life is going to look like. This is what life is going to look like at its best. This is what life is going to look like at its worst. You, Catherine, thinking about who your mom was. Would she stand in this door 10 years ago and say, this life is acceptable for me? Because that's the decision we need, not necessarily what I want for my mom or what you want for your mom. It has to be, what does your mom want for your mom? And,
Absolutely.
then we have to be strong enough as the sister, the daughter, the mother, to be able to honor that person and honor their wishes.
I think that the conversation around honoring that person is really important too. I kind of to that same point, what advice would you give to other healthcare professionals who want to improve their approach to those difficult conversations?
I think you have to give up being a medical professional and you just need to be a human. You need to be a human along with them being humans. You need to be empathetic. You need to understand what they're going through, the loss they're going to suffer, but also you have to help them balance that with the suffering the patient may have coming if we don't let them go. Sometimes the most loving thing we can do for our loved one is letting them go. Sometimes it is fighting through and being there every day, every minute to support them and say, you can do this, you can recover. Both are completely acceptable decisions. The only correct decision is what would the person in the bed want. That's the only correct versus wrong. If you don't follow their wishes, that's the wrong. It's not life or death is right or wrong.
I think that's a
But
really
I
good
think you
point.
just have to give up being a medical professional as if you're superior. You have to sit in a chair next to them, hold their hand if that's what they need. You have to make them know that you understand and that they really are the coach of this team. You're just enacting what they're telling you to do.
In the last podcast with Keon, founder of Independa, there is a statistic that came up that was kind of mind-boggling to me. And it was something like 50% of an individual's lifetime healthcare cost is in the last year of life. What role do you think hospice and palliative care plays in kind of managing end-of-life care costs and how those benefits can really be communicated to the patient?
I think palliative care and hospice are very misunderstood. I think people I don't think understand palliative care and what their whole scope is. But I think people hear hospice and rightfully so think imminent death. Hospice does not necessarily mean you're dying in the next day or week or month or even 6 months these days. It's not a diagnosis of you have to be terminal within the next 6 months to qualify for hospice. A lot of dementia patients qualify for hospice. And part of that is repeated hospitalizations, spending the majority of their time in the hospital system. Because when you have demented patients, one small UTI can lead to 3 months in the hospital system because you get the UTI. It takes your UTI is cured in 5 days, but it takes your brain and your body 3, 4, 5 weeks to recover from that. And before you're even recovered, you have another UTI or you have a pneumonia or, your dementia gets worse because you went to a rehab and it's not your natural environment. And so, things kind of start to spiral and it's hard to get the wheels back on the bus to get you out of the healthcare system. And so it just snowballs. And so I think, that's where a majority of that cost comes from. But that's also where hospice can set in and say, you're not going to die of this UTI, but you don't have to go to the hospital for it. Let's keep you at home. We can give you antibiotics at home, but we're not going to give you IV fluids and we're not going to give you artificial nutrition or a ventilator, those types of things. We're going to keep you at home where you're safe, where so your dementia doesn't further down the road. And you're going to be comfortable and you can do what you want. You can be in your own bed and you can eat what you want. If it's pizza and ice cream, great. If it's whiskey on rocks, great. It's just all about hospice is about what do you want in your life? What makes you happy? And then that is our goal.
Again, that quality of life topic comes up, right? With hospice, right?
Yeah.
I know that, dementia is kind of widely misunderstood, especially how we treat it.
Yes.
I'd love to hear your thoughts on that.
I wish we could normalize dementia as well. We don't officially diagnose it here in the hospital, but what we see is in neurology, we call dementia and encephalopathy like the cube of neurology, because as much as we see wounds in the hospital, we see encephalopathy in the hospital. And everybody has normalized senior moments and everybody has normalized, old people with urinary tract infections get confused. Old people with urinary tract infections don't get confused. Old people with dementia with urinary tract infections get confused. Often we're the first ones to say that to a family, and then it's like complete recoil from the entire medical team of my mom is not demented. If we could normalize that, I actually think it could be better treated. Yes, I understand that dementia is a terrible outcome. Ultimately, it leads to debility, worsening morbidity, worsening mortality, and that's nothing anyone looks forward to. But if we can catch it at the beginning and we can teach people to maintain social, physical, mental activity, if we can get them on medications like Aricept or Namenda at the beginning, it can slow that progression. It will still progress, but it can slow it. As a patient and a provider, I would rather know earlier so that I had time to prepare and see what I could do to slow than to know at the end and say, yeah, it's definitely there. And I think once we mention it and they recoil, they usually come back and say, well, now that I think about it, mom did do this or dad did do that, or we have been dealing with this. And then they start to kind of see how the signs have sort of been there. And as loved ones, we just compensate, not knowing that we're compensating for dementia. Well, yeah, dad messed up the bill, so I just started paying him. Why should he have to keep doing it? Yeah, he doesn't eat as much, so I drop off food. Those are all small compensations we do for the people we love that are actually covering the beginnings of dementia.
I think that really brings up a good topic around medical literacy.
Mm-hmm.
And it's a topic I think that comes up a lot around like providers, especially as we kind of attempt to bridge the gap between a lay person or a regular person's understanding of medicine and the medical diagnoses that trained professionals kind of have a really complex understanding about. Why do you believe that basic medical literacy is crucial for everybody? And how do we start to bridge that gap as providers?
Just throughout my career, especially in the ICU, yes, we're in the center. There's 12 glass doors around us. There's 12 patients. I could spin in my chair and see them all, but I can't see every detail of every patient. And so I've always been a huge proponent of teach everybody, because I don't care if you're the housekeeper, the tech, the nurse. I had so many housekeepers come up to me and say, I don't know, but there's something wrong with room 5. Okay, let's go. And then we'll teach about room 5 and what's happening, so that the next time, even if it's the housekeeper, they know, okay, this is what I'm seeing, because everybody is responsible to teach the patient. And the more we can teach family members about patients, the less they come to the hospital, the less panicked family members become. And if you can't be the eye of the storm, you're a part of the storm. And nobody solves anything in the midst of a storm. So even if it's a patient having a seizure at home, a cardiac arrest at home, right? The way we save cardiac arrest patients is by teaching lay people CPR. This is how you find a pulse. This is where you push. This is how hard you push. And this is your chance, right? So if you're confident, you've been to CPR, you know it. When somebody falls down in front of you unresponsive, check a pulse. You can maintain your calm. So I think, drawing pictures, showing pictures, and just even if it's basic education, helps everybody. It helps for better outcomes. It helps for people to not be panicked. It gives better information when the patient comes to the ER for somebody to say, this is exactly what I saw. And then you have a better opportunity to quickly diagnose what's actually going on.
I'm a huge proponent of everyone being CPR certified personally. I think that would really improve a lot of outcomes for people, when something like that happens, instead of relying on the potential maybe only one medical professional in the entire area that you're at.
Yes.
I think about that a lot on flights. I'm like, when they call a medical professional to the front, I'm
Oh,
like,
I've been
hopefully
that
there's more
person.
than just me, right?
I've been that person. And one of my critical care attendants actually was that person on a flight from St. Louis to India. And so he
Oh,
was
wow.
that person for like dozens of hours.
Oh my goodness.
But yeah, I mean, I just had to pronounce a little 24-year-old brain dead because he had a
Ugh,
seizure and choked, and nobody in his house knew CPR, and he was far
that's
enough
awful.
away that it took 24 minutes for the ambulance to get there.
That's awful.
I mean, he's 24. When I
Yeah,
started this, I was 24. Everybody was older than me, and now I have to call people brain dead that are almost half my age.
that's hard.
It's devastating. It's terrible.
Gonna pivot the conversation a little bit. I know that, there's some challenging things that we're going to discuss during this, especially as it pertains to patients losing their lives and having those difficult conversations with family members. But I'd love to hear a little bit more from you about what strategies that you use to help patients and their family members who are really uncomfortable and unfamiliar with the medical system and the complexities of new diagnosis. How do you really teach them how to be an advocate for themselves and teach them how to learn about their diagnosis?
The biggest things I use is in neurology, especially since I can show them an MRI of their brain and show them the abnormality. I try to show people images. I truly think a picture is worth 1,000 words. I am the best kindergarten artist ever for medical things. You would think after all these years I'd be way better at drawing them, but I'm not. So I try to draw them pictures. I will go online to reputable sites. Please do not Google things, and print off patient handouts. I use Up to Date a lot. Mayo Clinic and Cleveland Clinic have a lot of good patient education type things, and just try to sit with the patient, which is one reason I like hospital medicine. If it means I have to sit with them for an hour, I will sit with them for an hour to answer every last question they have, to make sure they understand the ins and outs, maybe not the most little intricacies, but the bigger picture of this is really what we need to be aware of. This is okay. This is how we deal with it, and just trying to calm those fears. So a big one we deal with is obviously dementia and leaving patients alone, but most new diagnosed seizure patients, their family members want them to have 24/7 eye-to-eye supervision. And it's just not needed. Like for seizure patients specifically, even if you're with them 24/7, you're gonna go pee at some point, and a seizure can happen that quickly. So you don't have to be there 24/7. There's lots of other technology that we can use to help those patients. People can put cameras in their house that they can monitor through an app, those kinds of things. So I think it's just calming those underlying fears, and generally I try to calm them through education.
I think you bring up a really good point, specifically around the amount of time that you're able to spend with a patient in a hospital setting versus an outpatient setting. A lot of the outpatient clinicians that I speak to, their biggest complaint is that they really can't spend enough time with their patients. And I think it's becoming even more of a compounding issue because we have a medical provider shortage in our healthcare system globally, right? Not just in the US, but globally. And, there's a ton of different estimates out there, but the most recent estimate that I saw is that the provided demand by next year, 2025, is going to be going up 17% because we have, our boomer population that's aging and they need care. And the provider shortage in the next 15 years is expected to increase to nearly 150,000. And that is just mind-boggling. When I read that, I was shocked.
Yeah.
The numbers there, those are just for providers. That's not allied health professionals, nurses, physical therapists, respiratory therapists.
Yeah.
And I think we're already really feeling the strain on that. And people feel like they can spend way less time with their patients. Has the shortage at all affected your workload or your ability to spend time with patients? And additionally, I guess, has the shortage affected any of your patients' access to care?
So, as far as me, and I don't, does it reduce my amount of time with patients? It does, but it doesn't. Yes, I have work hours. But yes, I also happen to have a very supportive family that lives down the street. So if I can't leave at 5 o'clock because my patients need something, then I stay because I have somebody that can take care of my kids. I don't trust anybody else to take care of my patients because I'm really super picky. Um, but as far as has it impacted, I think in two ways. Both the last hospital I'm at and this one are a little more rural, and we take care of a much wider expanse of patients. So I think telemedicine was a huge bonus because there's patients that live 2 hours away and they can't drive 2 hours for an outpatient visit. But they can certainly log on to an iPad if they have, reasonable service and see a neurologist. That being said, they don't have physical therapists or speech therapists or occupational therapists out there either. And right now, you wait 9 to 12 months to see a neurologist in an office. And so we do see a lot of patients that family members or the patient gets tired of waiting for that visit for their chronic condition. So they just present to the ER with, the pain in my feet is too bad because their peripheral neuropathy is what their primary said it is, but can't treat it anymore. It's not working, or the kids think mom has dementia, but can't get her in for the formal evaluation. They bring them to the ER with, well, mom's been confused for 6 months and we can't get in. We don't know what's going on. So we brought her here. Unfortunately, there are some things in neurology we just can't do a lot with in the hospital. We can't formally diagnose dementia in the hospital. We can't do nerve conduction studies in the hospital. We can try and, help to kind of quell fears or, kind of patch things through to help family understand or, okay, we'll do this until you can get in. But at the same time, those chronic illnesses are taking up a bed from an acute heart attack or, a massive acute stroke or, something else that is a right now problem instead of a 6-month-old problem. And I'm not at all saying that people should not seek healthcare for their loved ones, but it definitely is making a congestion through the system.
Absolutely. I know that there's been other interviews that I've had on here where There's one advanced practice nurse I interviewed who's a stroke specialist, and she, obviously it's neurology, and she said that a lot of the new Medicare guidelines as well have really altered the ability for patients to get in to see their neurologist, which is creating this huge gap in care, which can only lead to honestly worse outcomes for patients.
Yeah.
So telemedicine is great, but there's, I'm sure, many other things that we can do. And kind of along that same line, if you had unlimited money and resources to fix the provider shortage problems, what would your $1 million idea be?
I think, obviously I'm a PA, so I'm an advanced practice provider. And the original idea of PAs was to take military medics who already had medical training, give them a little more training, and then send them out to more rural sites in order to be a more independent provider where primary care doctors could not be profitable enough to sustain a private practice, either from not as many patients or, whatever. So I think, honestly, if we could train more APPs as well as educate kind of the whole everybody, but like my main attending actually supervises, I don't know, a dozen of us. And we all work in the more rural, smaller hospitals in order to provide neurology to these smaller areas. And I think if we could do that in more specialties, it would mean making attendings more comfortable working with us, which, even though I've been doing this 25 years, every new attending has to have their own comfort level with you. Then you have to have your own relationship. It's not like day one, you're independent and they trust you. You kind of have to, go through that vetting approval process with each one. But if more attendings were more comfortable working with us, more of us could be in rural setting. But then families and patients also have to be willing to see an APP as opposed to a physician. And I know, some of the time it's, okay, well, for 2 visits, you'll see, in the outpatient world. For 2 visits, you'll see Tori, and then every 3rd visit, you'll see the attending. So I think that's a good way to get APPs into more rural settings. Not that attendings couldn't, but attendings generally make more money than APPs. And so they're a little harder to stick someplace where there maybe isn't quite the population to support them. But also, I'm not saying APP should be relegated to only rural settings.
Absolutely. I think at the end of the day, we really just need more advanced practice providers and making sure that there is additional providers to see patients to kind of fill in that gap, because like you said, you have 25 years of experience. There's a wealth of knowledge. You've seen patients for many, many years, and you have a lot of value to add. And I think that, a lot of patients see that, but not everybody, right?
Yeah.
And, if we can help promote these advanced practice providers, whether it be nurse practitioners or PAs or really anybody who's been seeing patients for a long time, and especially coming from an acute setting into a more rural setting or other settings where they can kind of bridge the gap for, not having to wait 9 to 12 months to see a provider, I think would be really impactful for everyone receiving care.
Yeah.
Are there any other obstacles that you see as it relates to maybe technology or other types of barriers?
I think things that have helped care, I think EMRs are amazing. I have been exposed to a couple. The one I've used the most is Epic, not to plug people, but because it connects us so well with all the other hospitals, patients often don't know their own medical history as well as they should, as well as they don't know all their MRI results or their EEG results or, this, that. They don't remember all the medications they've been on. And so really having that connection with other helps to guide care immensely, because patients come in and think, okay, I have seizures. Well, what medicines have you tried? I don't remember. But I can go from my hospital's EMR into a different and find their last note to see they've been through XYZ. Okay, this is this. This is which then can normalize things for that patient because there's no normal. That's another thing I frustrates me is, oh, sodium was normal, but my sodium might be different than your sodium. And that doesn't mean mine's abnormal. It just means it's normal for me. Anyway, so I think telemedicine is great. I think EMRs are great because they help to really, cement things for patients. Barriers are distance, definitely distance and lack of providers. I think another barrier to a point is we all somewhat stick to our own specialty. So we don't necessarily I don't necessarily do CME in pulmonary. I don't necessarily do CME in cardiology or orthopedics. And so we all have a basic understanding of how they mix together. But to reach out and have those conversations with colleagues in other specialties, I think is a good thing. And maybe more CME that aren't as specialized, but maybe, do the whole realm of a disease process and how it impacts multiple systems. Like neurology and cardiology cross a lot, neurology and rheumatology cross a ton.
So I have one last question for you. What is one bit of knowledge that you'd like to impart on our listeners today?
Learn, ask questions, always ask questions, and never be afraid to ask questions. If a provider is aggravated by your questions, you probably need a different provider because you wouldn't go buy a new car and not ask questions. So why should a provider be insulted or upset that you're asking questions to learn? You're not questioning them. You're just wanting to learn so that you can do better, take care better, and those sort of things. So ask questions. Always ask questions.
Love that answer. I think that's so important. Thank you so much, Tori. I really appreciate your time today and look forward to catching up with you soon.
Yes.
And, this has been really great. I appreciate your time.
Yeah, no problem.
Thank you to all of our listeners for tuning into the podcast today. We appreciate your support. To hear from more healthcare voices like Tori Sutton, hit the subscribe button and share this podcast with your friends and family. I'm your host, Catherine Cummings, and you just listened to Healthcare Voices.